for coming out tonight to hear about this very important topic. My name is Suzanne Pichetti Johnson. I'm the program manager for Avenues to Wellness. We are a program of the Frank R. Howard Foundation, so a big thank you to the foundation for making the speaker series possible. I am very pleased to introduce our panel of speakers today. We have our moderator tonight, which will be Austin Peterson. He is a substance use navigator for Adventist Health. We have Dr. Michael Young. He is the director of the Medication-Assisted Treatment Program for Adventist Health. And then we have Marcia, who is a substance use disorder counselor.
Right.
Thank you very much for being here. And hopefully we will have 3 personal stories as well.
Hi everybody, thank you guys for all showing up. My name, as you all know, is Austin Peterson. I work for Adventist Health and I've worked there for about 3 years now. Just a little bit of my backstory. I grew up here in Mendocino County, and by the time I made it to high school, it was right around that time that's really popular in some of the pop culture right now. Opioid epidemic was in its beginning stages, with Oxycontin being very popular in my high school class. I didn't quite jump in at that point, but my longer journey through my young adulthood did lead me to experiencing some opiate use disorder. From about the time I was 18 to 29 years old. Through that time, I experimented with a lot of different drugs. But opiates were always like a really powerful hook for me. It was a big part of my story, let's say. I was introduced to Suboxone, which is one of the main points that we're going to be talking about tonight. Probably about halfway through that journey, a friend who I bought drugs from actually didn't have any, and he said, "But I have this this drug called Suboxone, and it'll help you. You won't get sick." And so I tried it out, and that was my first time ever using MAT medication. I didn't get it through a doctor. I didn't get it through a clinic. I got it actually from another using person with substance use disorder. The first thing I noticed with it, that it didn't have the up and downs, and that was didn't have this thing that addiction is very known for, which is the high highs and the low lows. I used it in that fashion as kind of a tool to stave off opioid withdrawal for a long time, and I continued to get it illegally from friends. A big part of my story, when things change, and I have been, without use, I've been abstinent from all drugs besides caffeine and nicotine for about 7, almost 8 years now. But a big turning point for me was when I found courage through support from family and friends to call a local clinic to actually start receiving help to stop treating this thing with my own diagnoses. I reached out to one of our local providers who I don't think practices medicine anymore, and I got involved in a MAT clinic. That was a real big switch for me, because all of a sudden, instead of purchasing this medication, I was in a MAT program. So I was going weekly at first to meet with a doctor in an office. It's a very different experience to sit in an office with a doctor than to be purchasing this from someone in their bedroom. I got exposed to counseling for the first time. I got exposed to group sessions with other people who were struggling with opiate use disorder. And for me, it wasn't like that was the moment that I walked and turned away from addiction, but it was a very important one, because it started to pull back a lot of shame and guilt for me about the way that I use drugs. And I got to see it as a medical problem and not a failing of my like morality or something like that. So I feel really blessed today to be working in the field. Currently what I do for Adventist Health is I screen patients for willingness to change inside the emergency room and inside the inpatient setting. So when people are admitted into the hospital for any kind of other illness, if they have drugs on board, I'm the person who walks in and says, hello, what's going on? I try to come in and not bring a judgmental tone to the conversation, because so much of the time our ER providers and our hospitalists and our nurses, very well intended, come in and try to inform people about the dangers of using drugs. Most people who use drugs either are very aware of the dangers or they don't really, it's not the way that it attaches to them, right? Because addiction is an emotional disease. And so, you can read people's stats about drug use and it kind of just bounces off them because the drugs make you feel really good. So coming in and just trying to meet people and give them a warm sense of belonging in the hospital has been a really cool thing that I've gotten to experience now with Adventist. And then in that, I call other providers, just like Dr. Young, just like Marcia, and we try to bridge the gap between seeing people in the ER or in the inpatient setting and getting them involved in something like medicated assisted treatment. It's really been a full circle experience for me to have been on the other side and now have these conversations with patients who, might not have had anyone come to them in this way to express interest in their lives, or, sometimes people who use drugs, they come off really guarded, and sometimes they don't, there's some friction there with medical providers. And so being able to, not always, some doctors are really great, obviously, but sometimes that happens. And to be able to be kind of that grease in between the wheels, and maybe it's not even anything but bringing someone who's experiencing homelessness a sandwich, but I'm really grateful to be able to do that for patients who sometimes or have been historically, I don't want to say mistreated, but they haven't had good experiences inside the hospital system. A lot of times how we enter the room with anyone impacts the way that conversation goes so much of the time, and our ER providers and nurses are so busy doing so many things that they come in hot, and very sensitive patients who are experiencing substance use, very sensitive to outside influences because of things like trauma, can get really guarded and kind of lash out. And being the one who is there to be a little more patient with them and help them kind of go through the cycle of, being the cycle of aggression where they get triggered and they have to express it, and then they come down and they're willing to sit and listen and get the medicines they need. Having someone to help walk them through that has been a challenging yet a very fulfilling role for me. So I'm grateful to do the work that I do and to be that kind of first responder to, in a way, maybe second responder, because really our EMTs do a lot and our ER nurses do a ton, so I don't want to take that from them. But being there to be able to bridge the gap for these patients and get them to someone like Dr. Young so that he can help them walk through the next stages of their recovery has been great. Again, just to highlight MAT saved my life is a really simple way to put it. I have gotten a lot of help from other programs of recovery, but MAT was the thing that got me stable enough to I could start listening to other people and get that help as well. And I want to give that back because the truth is there's a lot of misconceptions about what Suboxone and MAT is. What we're talking about here today is mostly buprenorphine. Methadone is another type of MAT that we don't really do at Adventist Health, but we do. My program does work pretty close with New Life in Ukiah, who has been doing methadone for about 2 to 3 years now, I believe. So we do have a local provider for that. But today we're focusing on Suboxone. There's misconceptions about what it is. Even in the drug use communities, there's this idea that why would you trade one addiction for another? Addiction has nothing to do with the drugs that we use, right? Addiction is the way that we feel about ourselves when we use. It's that cycle of shame and guilt and pain that brings us back to using. Alcohol is a good example of there are plenty of people in this world that can drink a few drinks and they don't hate themselves for it. One of the key indicators for being someone with alcohol use disorder is the continual use despite wanting to stop, and the shame and the guilt that you feel for doing that. And so Suboxone allowed me to stop feeling so guilty and start practicing healthy behaviors while not having to deal with acute withdrawal. Acute withdrawal is, the personal experience of that is pretty terrible. I think there are medical definitions of it that speak to the things like stomach problems and sweatiness and pupils and goose skin. But really that, like, the personal experience of having, it feels like you're sick and you know how to fix it, and you're disconnected and depressed in a way that's very hard to put into words, right? Like, it kind of feels like you're dying, and the only thing that fixes you is the thing that's also making you sick, and you're pretty acutely aware of that. And so a medication that allows you to kind of ease through that process, or maybe even like postpone that process while working on the other behaviors, is a big game changer. I'm glad people are interested in learning about what the reality of it is, rather than a lot of the misconceptions about what it is. I think that's about enough out of me for right now, so I'm gonna let Dr. Young take over and explain why he's here.
Okay, well, thank you. It's been an honor to be invited to this talk. So my name is Michael Young. I've been here in Ukiah with Adventist Health for the past about 13 years. Addiction wasn't really my initial interest. My initial primary specialty is in physical medicine rehabilitation, which mainly deal with musculoskeletal disorder. When I was doing my residency at University of Pennsylvania, at one point I was very interested in neuro rehab. It's just something that I always find it very fascinating. For whatever reason, I actually moved on and then did a fellowship in interventional pain management. So I've been practicing predominantly pain management throughout my career here at Adventist Health in Ukiah. Interestingly is that my journey is sort of with an understanding of how a chronic pain and people having to use opioid is what's sort of driven me to develop more interest in addiction medicine. Plus my initial interest in neurorehabilitation. So in 2015, I look into, that's when they came up with this XDA license for Suboxone. So I look into it and then got my X waiver, so I started to understand that more and more, and then that really piqued my interest in understanding how the brain works. Addiction medicine is a very, very complex field, Probably even the little kids would know what is addiction. But to truly understanding the disease itself, right? As you guys may know, a lot of time in medicine, many things has evolved. If you kind of look at the old literature, addiction used to be viewed as a moral weakness. That's why we have the 12-step. That's why we'll push people, okay, you got to do this a little harder, you got to be hard on yourself because you got to refrain yourself. Self-control. But now from medical literature, the current medical literature, we start to understand it's a brain disease. So if I ask you, if I ask somebody, do you have hypertension? And they say, yes, I do. Do you take medication for it, right? Initially, you probably, a doctor will tell you to exercise, and then if that doesn't work too well, then of course, you'd be on some antihypertensive medication. Now the question is, are you ashamed to say that you have hypertension? No. Now if I say that, do you have addiction? You can just kind of see the eyes changes, the expression, facial expression changes. Because addiction has come with this huge social stigma. And in my opinion, that's one of the reasons that how come we are still lacking in providing good treatment in addiction. When the patients are feeling addicted to certain substance, it doesn't mean that they're proud. I remember about a few years ago, I attended this seminar down in Monterey, or actually in Anaheim, California. It's a California Society for Addiction Medicine. And one of a lecturer mentioned that if I ask a group of young kids in kindergarten, right, what do you want to be when you grow up? And you can almost say that no one's going to raise their hand and say, oh, I would like to be addicted to medicine or be an addict, right? It's not a choice. It's actually part of programming our genetic. So if you look at the current literature, again, 40 to 60% are genetically related. So I think that's a very, very important message. So that being said, yes, there is a genetic component, but does that mean that what do you do? I mean, of course, then we all should first recognize that and that's how we can help the society, help the community, and we really have to overcome that social stigma. And that social stigma doesn't come with like this setting or counselor, but also providers, patients, their family members. So I think it's very, very important to really reach out to everyone to educate them what exactly is addiction. I myself have diabetes, and then I have tried exercises. I have tried eating right. Okay, it's hard. It's not easy, because the sugar is a part of addiction. Then, of course, to a point that my doctor would tell me that, you know what, I know you try to go running every day, you try to, just eating tree barks, but, your sugar is still not well controlled. Then that's where she recommended medication to control my disease. So same thing, with addiction. That's why we talk about, okay, don't be harsh on yourself. If you really try, then reach out to your doctor, reach out to the specialist here. That's where Suboxone comes. And then Suboxone, that also leads to another field of my interest, which is understanding how that dopamine. So the more I understand about that, right, I almost want to say, you know what? We all have certain type of addiction. If you kind of think about it, we all have certain type of propensity that we feel, hey, we don't have the full control over it. If you actually look at the DSM criteria, right now, even gambling just got listed as an addiction. So addiction is not only limited to fentanyl, heroin, all that stuff, it also leading to other behavioral therapy, right? Addicted to sugar, I can attest to that. Addicted to even so, video games, online, social media. There's been a lot of hot topics about that. Addiction even to many other things, And so it is very, very important for us to recognize that. As a physician, usually when I see my patient, I actually like to go into the neural mechanism. Because we need to have a true understanding. We need to understand what is a dopamine. How come when we are doing certain things, we feel better? But certain times, you just kind of feel so downright stressed out, anxious. And a lot of time, you cannot escape from the pressure from society. You just want something that can kind of take you away from reality. So when I talk to my patient, I have to say, I'm very, very, very grateful that I actually had the experience to talk to my patient, because my patients are how I learn about addiction. So about addiction to substance, which leading from a lot of environmental issue, how they grow up, understanding the brain development. So I always try to educate that. Try not to experience that, because you have to realize prefrontal cortex is the last part of your brain that's mature. Your prefrontal cortex is where you make that decision. If I say, go ahead, jump off the bridge, it is your prefrontal cortex who say, should I do it or should I not? Do I really trust this guy? What's going to happen if I do that? Unfortunately, if you actually started using those substances at early age, you would never get a full maturation of that prefrontal cortex. Then a lot of time, you based on your spontaneous instinct. You just want to feel good without thinking ahead. Then you're like, okay, I think I'm going to try that, without thinking that what's going to happen. Because you lose that inhibition to make you think twice or even 3 times. So that's why it's very, very important that our job is to educate the youngsters, because before they're 20s, 30s, right, they're still growing. And we need to understand the stages of their development. So if I can kind of like convince them, and then maybe you can consider if you really, really want to try, but after you're 25, 30, if you look at it, people who simply can drink, other people can control it. Once they have their drink, they're so happy. That dopamine kicks in, makes them feel really, really great. Everybody likes to feel great. But other people, right, they can simply take a drink. Okay, social drink, I'm done. I need to drive home, so bye-bye, then you can see those reactions and responses. And a lot has to do with their neurodevelopment. So it's very, very important that as a physician, I am also an educator. I need to kind of teach my patient and understand that. And then through Suboxone, which is a breakthrough medication at which I am very deeply appreciate for that medication, how that helps a patient, at least first thing, drive away that cravings, right? It's a lot of times it's that craving, something that triggers you. If you are alcoholic, you will never want to buy or rent an apartment next to a bar. right? Because all those stimuli simply can just kind of make you have that tingling sensation and making you wanting to do it. So a lot of these things that we really try, to help our patients. But of course, I'll be happy to go into, how the medication works, buprenorphine. In my medical career, I feel that if the patients or if any persons who suffer any sort of diseases or disorder, if you can explain to a way that they can understand, because the power is within them. We are just cheerleaders, but our job is to really, if I can kind of explain them to them and they can fully, or at least they can grasp the understanding rather than, addiction is a bad thing, you're a bad person, or just move out of here, ostracize themselves, right? That's what we're seeing. So they need a lending hand, and that's why we want to do that. Anyway, I'm going to turn this talk to Marcia.
Well, hello, everybody. I just want to say thank you so much for coming, first off. And number two, I wanted to say that I think I'm really blessed that I'm sitting in a chapel right now, which has just got a lot of, good feelings. And so this is just kind of exciting for me to be here. I'm going to explain about my where I came from, my past a little bit, and then move on from there to the current program that I'm working. So my actual past, I was very interested in experimenting with drugs and alcohol as a young person, and that continued for quite a while. And I got to a certain point in my life when I wanted to make some changes, and I decided I didn't have any job opportunities that was available to me because I spent too much time experimenting and not enough time doing actual jobs. So I decided to go to school and went to Mendocino College, and I did about 4 years in Mendocino College. I completed the intern class and the certification class, and graduated with flying colors, and decided to be a counselor, which was very interesting for me. So this is back in 2002, excuse me. 2002 was the first year I was actually working with substance use clients. My title is a substance use disorder counselor, or back then we called them substance abuse counselors, which sounded like we were abusing them, but So my first job was at Ford Street, where I did my internship for 2.5 years. I was there at Ford Street, and I monitored the patients in detox and worked graveyards and stayed up all night, and did paperwork and little tidbits of things, and then basically watched the facilities because there was a lot of cross addiction and sexual addictions going on, with the patients and stuff. So it was like a cat and mouse game a lot of times, chasing people out of the corners of the yards and things. So it was always think something going on, and it was always fun to spend my time searching around for what people were doing, making sure they were in their beds. So I did that while I was going to school. I went to school, I went to work, and I went back home, and then I did my schooling the next day. So it was like, it was pretty full, where I didn't get a lot of sleep, and I really committed myself to wanting to make this work. So I went ahead and finished my internship hours, which you actually have to do a year or more of full-time work. And so some people can do that, in the first year, but for me it took me about 1.5 years to get the intern hours that you need. And then I went out and tested. We actually test out in Sacramento, and this takes time in college, so it's not a really easy thing to do. It's very, very challenging, to say the least. So after I left detox and actually got certified, I started working with the mental health clients, and this is where I fell in love with what I was doing with counseling. Was that I decided that I wanted to be more with the co-occurring clients, which is when you're working with the mental health clients, along with the people that have substance use or substance abuse history in combination. And I found out that it was really good because I was able to stay non-judgmental and open to whatever their journey was. And I wanted to say that I have had so many years of sharing stories with people that I feel really grateful that I've had all this time with just thousands of different stories where I've heard some really horrific things and some real joyful things, and it's really helped me move ahead in my life and realize that a lot of people struggle in really hard ways, and substances is generally the way that they go to kill their feelings and to deal with, what's going on and need to numb. And so I actually progressed through my position with 4th Street, went to the county, was with the county for about 13 years, left there as a supervisor in 2018, and then decided to go over to Redwood Community Services and work as a mental health rehabilitation specialist, where I was working strictly with people that were either didn't meet criteria. I was doing 5150s, working with patients that didn't meet criteria to go to psychiatric care, or they came out of psychiatric care and they needed more help. And I did that for about 3 years, and I loved it. And I learned a lot more about mental health and diagnoses, and working with clients is that the clients that have not only the substance use piece of that, but they also have the extra energy or extra obligations to work on their mental health at the same time. And I want to let you know that what I've learned in the time that I've been counseling is that it seems like all the substance use that's coming about happens from some kind of traumatic situation or something that happened in their childhood. And we always want to go back and say, well, what happened? What was your relationship with your parents, or what happened as a child? But I can tell you that time and time and time again, with all the stories that I've heard, that there's always something that happened or happens to the people where they really struggled. And what they did was they just went to the easy street, which is they started drinking, and maybe that drinking didn't work for them, so they started smoking a little pot, and the pot didn't work, and then they started using a little speed or a little heroin or whatever, and they just got worse and worse and worse and worse, and they never really dealt with the trauma that was pushing them to numb all their feelings. I've realized that counseling is the one important piece that makes it different from just quitting drugs. It's actually connecting and making sense out of what they've gone through and where they're at to where they're going, and you try to put the pieces back together so that they can actually start working on a journey that's productive and safe and healthy. And so I decided I wanted to be that counselor, so I just kept going. And so I was really successful at being able to start working with Adventist 1.5 years ago with the MAT program. I love it. So what I'm doing now is I'm a substance use disorder counselor, certified now. I'm in my 22nd year of counseling. And so I started in 2001, and now we're in 2024 and still going strong. I want to let you know a little bit about the program that I feel is really important for what we do with the medication-assisted treatment program. These clients or patients, we call them patients or clients, the patients that come in are there at their last straw of life most of the time. They're not, if they're ready to change, then maybe we get them, but usually they're in the place where just nothing's working. I mean, their whole life is falling apart, and they've got nothing going. They're sometimes out of a house to live in. They're unhoused. They have no food. They have no clothes. They're living on the streets. I mean, it's pretty intense, the kind of horrific lifestyle they're living in. And then all of a sudden they decide, well, I want to, I don't want to do this anymore. So with the opioid clients and also some of the other substances, we're able to bring them in and have a screening and a kind of a small assessment and spend some time with them. And what I do with the patients and the clients that I work with is I think I inspire hope, because if it wasn't for people that assisted me and inspired hope in me, that I don't think I would be doing the job I'm doing today. So I think what I do is I help inspire hope, and it gives them determination to want to change and want to be better and want to move ahead and want to be normal and want to be part of regular society, and they want to go to work, and that person's in there. And so what I do is I set them up for either, depending on their level of need, they start at like 2 times a week or 1 time a week, and we cater to the need of the particular client. Once we do the paperwork and stuff, then they go over to see Dr. Young, and Dr. Young induces them with, and he has these long conversations with them, which is just really cool. We go in there, and these people are, I mean, they're ashamed, they're embarrassed, they're feeling guilty, they're feeling all these feelings. We're asking them to take away their only friend, which is their drugs or their alcohol, and follow through with doing some improvement steps and maybe doing some goals, and maybe going to meetings where there's strange people that are going to be into their whole reality, and maybe that doesn't feel so good, and not church, because church, I've never been good with God, and so how do you, so they're all set back and very concerned and very nervous, but they show up, and Dr. Young's got this way with them. He makes them feel comfortable. He introduces everything, explains everything so matter of fact that it makes a lot of sense to them. And they try this thing called Suboxone, right? And they get on the Suboxone, and then I'm getting phone calls the next day from these patients saying, I don't feel like using today. I just started using it. It was like 6 hours, and all of a sudden I didn't feel like using any drugs. And so I think I can do this. And all of a sudden hear this whisper of hope from somebody. So what we do is we just continue to monitor and counsel and have them go back and see Dr. Young on a 1 to 2 week or a month schedule, depending on their circumstances. And he continues to inspire them, and then they continue to inspire themselves. And then in my counseling session, we work on goals and treatment planning and motivational interviewing, a little bit of cognitive behavioral therapy, and trying to get them to use their mind and change their thought and make new decisions in their life, make new courses, and look at things ahead that might possibly happen and work towards those things. And so what's happening with our caseload is it's really become a miracle. Way we work it with the MAT program here is we keep a spreadsheet of Willits. I work at Willits and Ukiah right now. I'm covering for somebody in Willits that's out on maternity leave, so I'm actually covering the 2 sites. But our patients, they never leave our help. Once they're a MAT client, they're always a MAT client. So we get a lot of returns back to do like aftercare or return care. And so it's open to them coming back anytime they want, which is really neat. But we've actually mapped out these large spreadsheets, and the people there are doing really, really good. And we're having a lot of successes, and I'm really amazed. And so then the cool thing about it is they don't feel like they want to use. They don't, because of the Suboxone. The Suboxone keeps down the cravings. It helps with the Suboxone withdrawals, and it continues to support them. And with Dr. Young, he's always, changing their medication or maybe making it a little stronger or reducing it if necessary. And they actually learn how to function as a normal human being. And I've watched this over and over. And now I'm getting the pleasure of working with these people, these clients that are telling me all these wonderful things that they're doing. And it fills my heart up with a joy. It's amazing. The stories I get to hear, I mean, these horrific stories that come in, and now they're talking about, I just looked at a used car, you know, or I've got a job, or you know, me and my wife are back together again, or one of those speakers that didn't show up tonight, I get my children are coming back from CPS, and I've got my 2 children back. You know, just all these different wonderful stories we have. So that's the Suboxone program here, and like I say, nobody ever, you know, technically graduates. They can get a graduate certificate, but they never graduate. They're always kind of under our watching eye. And I'm just really blessed that I have had the opportunity to hear all these stories and to be able to watch all of these improvements and these miracles and these people that have turned their lives around, that are part of our society now, that are in these. I'm trying to think of some, you know, like Joey was going to talk. I don't know what happened to our speakers that were supposed to come. We were supposed to have 3 of them. But Joey, he's actually working at First Carpet One, and he's like a carpet layer and stuff like that. And he's got his own apartment, and he's driving a brand new car, and he's got 2 years clean, and he's just doing really, really well. And he said he had a bout of the strep throat and wasn't sure he could make it, but he was going to wear a mask, and he said he'd come. But he's not the person. He was the person out there using the fentanyl and using heroin and you know, using really hard drugs. And he had no interest of, you know, stopping. All he wanted to do was use, and now he's gone through counseling, and he's living like a really productive life. And I get to watch that and glow behind it. It's all his work, but still, it tugs at my heart, and it gives me enough ammunition to go to the next one and the next one and the next one. And I don't think I'm ever going to be done, because there's always a next one, you know. So what we're hoping is that we're going to get this information out to the public and get people to let other people know about the MAP program. There's cards on the table, and there's flyers, and we have openings for new MAP clients all the time. We have groups. We have 2 groups in Willits. I have plenty of openings. I work in Ukiah 3 days a week. I work at Dr. Young's office. I work at Redwood Medical Clinic. And all you got to do is call for an appointment and send them in, and then all the magic happens. It's just one phone call does it all. And so I just wanted to say that if you know of anybody, or if you can get the word out to the community that that program exists, then I would be really appreciative, and I would just love to have more clients coming in, you know, on a daily basis and watch their miracle upon miracle upon miracle, you know, and just continue to fill up my heart at the same time. Thank you.
Thanks, Marcia. First of all, I did not know you had been serving this community for 22 years.
Yes.
That is amazing. I think that's so admirable, and just thank you for that.
Mm-hmm.
I do have some questions, but I would kind of like to open it up to anyone that's here, since we're all sitting here, and for your questions, because they might be more helpful. You got your hand up.
Yeah, thanks. So I have a couple of questions of just how it all works together. You said you have openings and people can come from Willits, Ukiah. Are you on the coast as well?
We are on the coast as well.
Okay. And it isn't quite clear to me what are the requirements to be able to come to you. Obviously, the whole area of substance abuse covers a wide area and different problems. What qualifies you to be able to come to your program? And I want to hear more detail about what you do once somebody comes in and what the process is.
Well, actually, you know, we don't have any requirements at all. What I do is simply kind of what Austin does is I meet the person where they're at, and then we talk about what the next step is, and it might not be treatment through the medication-assisted treatment program. It could be treatment through another agency, or we refer them on. So I do a lot of referrals. I do a lot of referrals to residentials because I don't think it's the right level of care for some of the people that come in. But I do track them through with phone calls and cards, and sometimes bags of beading stuff so they can bead while they're up there and stay connected. So I'm there waiting for them when they come back.
So in addition, also, so insurance pays for a lot of what we're talking about. So one of the things my role takes care of is making sure you're showing up to the right place for the right insurance. Medi-Cal partnership benefit pays for a lot of these, and before they make it to the MAC clinic, helping them find or switching to another clinic, because everyone has the right to choose where they get their medicine. That part can be a little complicated, and it can take some patience to call a partnership, to walk through the phone trees, to make sure that you're going to go to a place that can see you and bill for your services, right? To make sure Dr. Young can see them, and Dr. Young's not coming out of his own pocket. A lot of the MAP programs, and I believe there are still grants available for patients who are underinsured, meaning that we have tried different routes to get you insurance, but for whatever reason you cannot have insurance right now. There are grants that cover some of those patients and early access to MAT. Also MAT is available at the emergency room, and that is a little, we are trying to hit 100% where you can come to the emergency room and you can receive Suboxone and other MAT all the time. We have, and the nature of the emergency room is which doctor's on, but we make sure that we bring those doctors in and try to educate them on the usefulness of MAT. Emergency rooms cannot turn people away for services, so that's one thing that I think we're all happy for, is that someone who's in crisis can come get a medication for a short term, meet with someone like me if it's during regular business hours, or get a referral to someone like me who then connects them to someone like Marcia and Dr. Young. So basically anyone can come. There are some things that we do have to jump through, but that's why we're all here. So I hope that answered.
Yeah.
So they don't have to have an opiate addiction as part of it, or they do?
No, actually, one cool thing is I'm not sure that the grantor, that we're under a SOAR grant, which keeps me partially busy. So what I do on the time that I'm not busy, the grant pays for my, me functioning and my time and whatnot, but I have extra time, and so what I do is I open myself up to other, like alcohol use disorders. So I counsel for them, and I also counsel for people that have, like if they have had previous, like stimulant use and they're craving it again, I counsel them. I also counsel people that have like smoking cessation, and they stop smoking cigarettes, but they feel stressed out and they're going to go back to smoke cigarettes. They totally work for me too. So, and I see all those people for free. So what I do is I put a note in the computer and then I no charge it. So a lot of the patients that I see right now are riding without any, they don't need any insurance. They just walk in basis. So it's as easy as calling Redwood Medical Clinic and talking to the appointment person, which is I think #1 on the phone, and just saying that you want to see Marcia, and then they'll just hook you up with the appointment, and that's really how easy it is. In Ukiah, it's another number which is listed on the flyer or on my business card, but it's basically the same thing. You just set up an appointment, and then we talk about what's best for the person that I'm there with, and then if it's best with us, then if they're not opioid, then they're free. And so the grant takes opioids and stimulant disorders and not alcohol use disorders. And so I've got a lot of alcohol use disorders that I work with. And of course the opioid and the stimulants take precedence over the grant because it's grant funded. But I keep very busy by providing free services to people that can't afford it, which I really love, whether they're insured or not. Did I answer your third question?
Yep.
Okay, yeah. So I think it's that easy. Although he'll catch them at the emergency room, if I meet anybody, just tell them, just call Redwood Medical Clinic, and at the scenes, I need to see Marcia, and they'll just make it happen, and it's kind of a magic.
All right.
Yeah.
Okay.
Is Suboxone, I understand that it really helps with the withdrawal phase of opioids. Is that a medication people stay on forever, or how does that work, or do they wean off of that?
So, so to really understand why Suboxone use, if I can kind of give a little brief about the neural mechanism of addiction. So basically, addiction, one thing we need to understand is that dopamine, right? What sort of dopamine is what sort of create that happiness, feeling good, and there's a lot of stuff that can lead into dopamine release. Let's just say that somebody who doesn't have any substance use disorder, it will be food, sex, basically even exercises, endorphin, dopamine, and that's how we function. However, when people use let's say alcohol, opioids, smoking, right, all these, right, even gambling, they start to create that dopamine. So when they're in it, then they start to feel great. But when the dopamine start to come down, then you start to go into a bit of a negative withdrawal. Then you just kind of you start to developing this craving, wanting more and more. I don't know if you guys heard of a term called tolerance, right? Tolerance will be something when you use it first, it gives you that level of satisfaction. But then over time, you need a little bit more to achieve that type of satisfaction. So that's how a lot of people end up, unfortunately, have unintentional overdose with opioids. Suboxone is actually an opioid partial agonist. So Suboxone is mainly indicated for treating patient who has opioids. If somebody's got alcohol, Suboxone is not FDA indicated for that. Okay, if somebody's got gambling, you don't give him Suboxone to treat that disorder. Mainly Suboxone bind to your opioid receptors. By binding to your opioid receptors, right, compared to morphine, Percocet, and fentanyl, right, Suboxone has a high affinity. What that means is that it binds onto your receptor very, very tightly. But it's a partial agonist, so if you kind of use a lot more, right, it actually protects you. It has a sealing mechanism. And that's the main difference between Suboxone and morphine, fentanyl, or Percocet, those street drugs. Because when you use those, right, it doesn't matter. The more you use, the level escalate. When it escalates to a point that actually surpass a threshold for your respiratory center, boom, that's how people die. People die from opioid overdose are mainly respiratory depression. That's less likely other causes, unless they have other underlying medical condition. But it's really that breathing part. They stop breathing because opioids suppress all that breathing center. So Suboxone has that protective mechanism. Now Suboxone is also an opioid. When you actually cover your Suboxone, cover the opioid receptors, right, that prevent the fentanyl, the other morphine bind to it. So it's like you have a cavity and then we put a crown cap onto it, right? So people, if they say that, okay, I use Suboxone, what happens if I use morphine? Well, actually, physiologically, the morphine will have a little lesser chance of binding to the receptor because Suboxone has a stronger, so it's protecting due to that affinity. So when you are on that, one thing that Suboxone has proven is that it suppresses craving. Now all the opioid receptors are sort of suppressed. You do get a sort of a level of dopamine release, but at least you don't feel like, oh, I want to get something so I can get high. So that's why that's a really the best use I can say about the Suboxone medication. Number two is that how long do they have to be on it, right? So when they are on it, right, this is where when we start to induce them with Suboxone, because they are having all this craving, they have withdrawal, right, and now they're stable on Suboxone, right? By the current literature, they say at least wait for about a year, okay? And why is that? Because a lot of times if they say that, I feel good, I don't need that anymore. They're walking, all of a sudden they run to their friends and say, hey, try this, then that's called relapse. So while patients are on Suboxone, this is where Marcia and Austin, their role come in. Because even though we're using medication to control that, you still, I don't know if you remember, I said the prefrontal cortex, making the right decision, motivation, motivational interviewing, cognitive behavioral therapy, that's their expertise. that'll help patient to say that, okay, how can you make better decisions now? How do you actually strengthen that inhibition to make think twice? How do you actually control your self-craving or self-control from relapsing? So during that time while they're on Suboxone, they're actually try to heal these patients, either trauma experiences and things like that. And then we continue to monitor, and the patient, everything they doing well, then we slowly taper them off, and then they can be off on the Suboxone medication. Some patient may just kind of feel, I feel more safe while being on the medication, and that's okay, and that's kind of like in a nutshell,
So you talked earlier about you don't do methadone, but somebody else does. Is there a different indication of why you use Suboxone as opposed to methadone?
Yeah, absolutely. Methadone has been around the block for much longer years, So methadone, it just is being around for a longer time. Methadone itself is what we call an opioid agonist. Why methadone it was used to treat addiction? Well, number one, because methadone has very, very long acting. So imagine that if you take something, right, that stays in your system for long acting, then of course, that at the same time, you're less likely to go into that deep withdrawal symptoms, and then that kind of keep you, at a more therapeutic level. Methadone, at the same time, it doesn't have the sealing mechanism, the protective mechanism like Suboxone does. So let's just say that some people say, oh, methadone works, but they accidentally take a lot more, okay? Yes, that can surpass and then suppress their respiratory center. Suboxone, on the other hand, is a partial. So if you take it initially, it goes up here, but if you just take it more, let's say unintentionally, accidentally, right? Because it's a partial agonist, it comes and goes. So you maintain at the level without surpassing that. And that is really the best part about that medication. So that's the reason why I do that.
And one of the other reasons for methadone is one challenge with Suboxone is when someone has just used, their opioid centers are very full. They're experiencing high levels of euphoria, and that's maybe even their baseline. When you introduce a partial agonist to their system, the higher affinity kicks the fentanyl or other opiates off, and they will go into what's known as precipitated withdrawal if you induct too early. Methadone doesn't quite have that danger, and so it can be easier to start really behaviorally health challenged patients who can't even go an hour without using on methadone because you can taper more easily. Also, patients themselves may have had a bad experience when being induced on Suboxone too early, and they're get a triggered trauma response from the idea of being on Suboxone. So methadone can be I don't want to say safer alternative, but it can be an easier sell to the patients to come into a clinic setting and start being introduced to behavioral health technicians and counselors to move them along that journey. And some people do, it doesn't happen often, but some people do go from methadone to Suboxone eventually because it is less regulated and it's easier to. Methadone clinics, you still have to go almost every day, and Suboxone, you can get longer scripts.
Or counseling or anything,
Yeah.
Yeah.
we need more
First
tools
off,
in
I
our
think
belt.
Suboxone's safe with pregnancy, isn't it?
Correct. So actually both methadone and Suboxone, they have been advocate that pregnant women should continue being on that medication.
Right.
And this is where the concept of harm reduction, because number one, let's just say someone is pregnant and then you cut off their opioid medications or even just the opioid product, then there's a likelihood that the baby can develop what we call a neonatal withdrawal, abstinence withdrawal symptoms, right? And then that'll be very, very bad. So harm reduction, concept of harm reduction means that when we're making a choice, is a patient benefit more or is it risk outweigh the benefit? So, and that therefore, to answer your question, Suboxone can be used. A lot of people say using Subutex. Subutex is a buprenorphine product without the naloxone. If you guys ever seen Suboxone, you'll see that there's a little word called naloxone, which is 4-to-1 ratio. Naloxone is actually, they added because they don't want people to abuse it. For example, some people would actually, basically boil the Suboxone so they can inject it into their vein. When they have naloxone injected into their body, naloxone will interfere with opioid and make them very sick. So that's why they actually invented that. Subutex is a very, very pure buprenorphine. So in the past, they say that using Subutex may be more suitable for pregnant women, but I think the most recent study did not show that. So Suboxone or Subutex are fine. Yeah.
And buprenorphine is the chemical compound name, while Suboxone and Subutex, and there's also Sublocade, those are all like name brands, right? So the Suboxone and buprenorphine are basically the same thing. Us who work in the field sometimes use them interchangeable because they're very similar. Yeah. So,
but I also want to point it out that Suboxone does excrete it in milk. So if you decide to breastfeed, but they still think that they recommend you continue breastfeeding it. Despite that, yes, study did show that Suboxone can be excreted through breast milk.
yeah, the newest data does support all of that. I have seen methadone does, the only counterindication is that it leads to lower birth rates. But I think the idea that having someone stable on a medication overall leads to better outcomes than someone returning to street drug use and all of the dangers that come from that, i.e. physical, emotional, and stress. And overdose. And it's definitely where there's a lot of stigma still is around, of course, and I think almost rightfully so, around children and drug use. But it is something when you see the statistics on the outcomes, it does kind of force us to look at these things and say, hey, these might be our feelings, but what has actually come of these situations where parents are benefited from continuing to be on these medications despite our, feelings about the baby in utero. So.
I also want to let you know that I actually am cleared for 15 years and older. So, there's adolescents that that they can do the same thing, make a phone call and see me over either at the Ukiah office or at the Willits office or at Dr. Young's. But also we have a really good pediatrics department too that's actually, and I'm not sure a lot of people that behavioral health has, that services, and they occasionally have openings. So for the children that seem like they need counseling because of things that are going on at home.
Are there MAT services for alcohol abuse?
So, as I was saying, a lot of product leading to the releasing dopamine. So Suboxone doesn't really treat that. I don't know in terms of MAT services, but for alcohol, right? Currently, the main 3 FDA indicated medication will be antabuse, Camprose, and then Vivitrol, which is naltrexone. So these are basically a way to tackle patients who suffer from alcohol use disorder. So I don't know if that sort of answers your question. I don't know if that's including the MAT service.
So I think there definitely is.
The MAT services.
I think there are, and I think one important message for alcohol use is that there are medications for acute alcohol withdrawal that are very important. And if someone is struggling with alcohol use, to come in and see a doctor either in a clinic or in the hospital, and to get involved with counseling. Counseling is such a huge thing of this whole thing that we're talking about is long-term success is based on changing behavior, right? So, but acute alcohol withdrawal is very dangerous, and medications are available for that. So that's would be kind of like an MAT service, but it only lasts a week because those medications on their own are very dangerous. But then there are the medications, Dr. Young, for longer term with counseling. But it is a little different. I don't think it's quite the same as the way that Suboxone works for opiate use.
We also have a detox facility right here in Ukiah, so.
From alcohol or
For
any
alcohol,
drug?
Any drug.
Any drug.
And they just opened 8 new detox beds, so I think they're up to 18 patients at a time that can go through detox.
Through URC or 4th Street.
Yeah.
Yes, I do. Yeah, so it depends. It really depends. Number one, of course, pain, that'll be more my expertise. Truly understanding where the pain is coming from. Pain isn't probably the most simple 4-letter word that even little kids understand. So far we understand there's a huge difference between acute pain, which involved with the tissue damage, somebody who's got a heart attack or their arms and legs got cut off, and then there's a chronic pain. Chronic pain, a lot of time, is actually basically is beyond that. It's really not just acute pain that lasts for more than 3 months. Chronic pain actually involves a lot of how your central nervous system processing information. We call that, I mean, I can't go into that, but it will be very, very complicated. So in somewhat, it involves numerous parts of your brain. So that's why if you see people with a chronic pain, right, you're literally talking about biopsychosocial approach. It's really not just a medication injection, but up here, amygdala, all that emotional aspect of it. Chemical dependency, for example. So basically, so does it mean that every chronic pain patient should be on buprenorphine or Suboxone? No, not really. It really depends on very much individual assessment. So basically, before you want to try Suboxone, very, very good evaluations. Number one, because if you actually look at the Suboxone, which is in milligram, right, which is actually pretty high dose, there is a buprenorphine product, right, that's in microgram. That's actually more indicated for pain. It's known as Belbuca or Butrine patches. So these are actually more FDA for pain. Number two, if somebody who's actually hasn't tried any opioid medication and you just put them on Suboxone, right, they'll be like a zombie for the next 24, 48 hours. It's just too much. So definitely I would caution that, just because, Suboxone itself, it is still an opioid medication. So that is something that, we need to, pay attention to.
One question I have is, Marcia, do you know the statistics, percentage of recovery for opioids in the nation?
Yes, I do. According to the last, what I could find, it's 2.2. And I wanted to let
2.2%?
2.2%, which is, and I'm monitoring 70 different cases right now, and out of those 70 cases, 34 I have 2 years and under and are testing clean, and they're actually clean, thanks to Dr. Young. And I want to let you know that we're at like just a bit under 50% on our,
Wow.
yeah. So our program really works, and I just wanted to say that. Isn't that? Yeah, good job, Dr. Young.
For me, one of the most engaging, and it's something that with some recent events hasn't been a big part of what I've been able to do, but is the warm handoff that occurs when we walk someone directly from the emergency room to the office and to Marcia. So they're really just, with one of us the whole time. That brings me to the question, which is, what do you find most touching and engaging in this line of work?
I think it's when they get their first clean test, and then their 30 days, and that's the most touching time for me. I actually have people crying when they reach their time where they get a birthday. I buy muffins, these really cool muffins at Safeway and stuff like that, and do a birthday candle and the whole 10 yards, and like sometimes little, something else or whatever. So I kind of make it a big deal that I actually chase them down to meetings or wherever I need to find them, just to make sure that they get a muffin. But yeah, and that touches my heart, because you can just see that they've really decided that they can do it, and that they've got hope for the world and for the future, and their lights are on, and it's a beautiful thing to watch. So.
Cool. Dr. Young, same question. What do you find most engaging?
I think most engaging is basically what's most empowering, that once that chemical dependency or substance use disorder is being treated, now they're able to move on to the next step. So for me, it's kind of like a parent, and then you want to watch your kid start crawling, walking, start running. So what sort of struck me the most is that now my patients are telling me that they have a job, so important, and they're supporting their family. Because part of my goal is really not just substance use disorder, but we want to bring you at one point you were ostracized. You will feel like you're just that corner. You cannot work. You have to be on disability. You're poor. And now, just like Marcia mentioned, one of our patients, he's like, Dr. Young, check it out. I bought this car. And I was like, wow, that car is better than mine,
Take it back.
So yeah, so it's so empowering that now they're able to depend on themselves. When they suffer from substance use disorder, right, basically they don't even have that self-confidence and esteem. They just want a drug. All they want is depend on, am I going to get some drugs tonight? and now they're able to hold down a full-time job, able to, you know, even like start to have their own apartment, a place of their own, and they share that with me. I just find that I'm just very, very grateful, you know, that yes, we are making a difference, you know, in their lives. Yeah.
One thing I wanted to comment and ask you about with trying to reduce stigma and get people to realize that addiction is, you know, a medically oriented thing. It seems like having the connection to the hospital, where somebody's coming into a hospital rather than going to a treatment program for heroin addiction or whatever as an entree, you know, just having you there seems to me reduces stigma. And so added to that, I wonder, in the hospital setting, who do you see? I presume some people you would see from emergency would come from an ER, would be in an ER either for an overdose or for a medical, you know, emergency. Would you see people that way? Would you see people that are in the hospital at other places who would come and then somebody would know, hey, we ought to check it out through the map?
We try to see all patients who have, with some exceptions, right? We don't want to be trying to help so many people that we're actually creating more stigma, right? So if a patient politely declines, then we do not see them. But the SUN program, the Substance Use Navigator program, is embedded in the hospital system, specifically the ERs. So we do meet with a large portion of the patients that come in that have substance use disorder and anyone who uses drugs. And we try to have those conversations, right?
What would bring them into the ER though?
Cellulitis, infections.
Okay, it could be anything.
Anything. So, and that is another beautiful part of the program, right? Is people who do drugs deserve medical attention, period, right? And that hasn't always felt true. I think some of the populations that I work with, people would drive to Willits because they, for some reason, think the Willits ER is friendlier than the Fort Bragg one, and people from Ukiah will drive. People do this thing because they were treated maybe harshly once, right? So they come in and they get to be seen for hypertension. I already said cellulitis. Sometimes abscesses. I look for things like, yes, neuropathy, CH, congestive heart failure is common with acute, long chronic meth use, opioid use disorder. Most patients are coming in for either overdose and or withdrawal symptoms. So they'll have things like stomach cramps, nausea, vomiting. We do see, it is the age of fentanyl, so overdoses are happening more and more, and it is rather sad. But, we see those patients, obviously, if they stay. A lot of times patients who have just been reversed of an overdose tend to leave against medical advice because of how acutely in withdrawal they are. But we do try to meet all those patients. But again, drug addiction I think there's a very clear idea of what acute, like in the moment, this person's obviously under the influence of lots of drugs looks like. But that's not also true. There are a lot of people who come in for hip problems because they're, just like everyone that's getting older, they're having mobility issues, right? Some of those people we have conversations with about receiving resources. Not always MAT, but sometimes residential treatment, counseling, behavioral health. Sometimes addressing the underlying causes leads to lower drug use, which is what we're kind of after, is quality of life, not just abstinence. So pretty much everyone.
And where are you located yourself?
I work mainly out of Howard Memorial and Mendocino Coast hospitals. I do spend some time to cover shifts at Ukiah Valley. So,
what I wanted to say and compliment Austin too is that when he has patients that end up being admitted in the hospital and stuff like that, then he can contact me and then I can use follow-up and use it as counseling time, basically. But actually develop my relationship with them while they're in the hospital getting better. And so the relationship's already available and not available. It's present and developed by the time they get out, and so they're all ready to go see me. So that and I just love it when that happens with him. Is he basically is handing it over to me and I get to go with it, send it, because it's right up the stairs for me. So yeah, it's fantastic. That's the kind of teamwork I'm talking about. It's really works really well. I wanted to say that there's a lot of infections that are starting to happen because of the xylazine, that's the horse tranquilizer that they're using, causes eruptions of the skin from using it as IV and stuff like that. And so we're going to start seeing more of that. There's another drug out there called ice, and then there's another one called crocodile that's coming out, and they continue to use these via IV, and what's happening is it's actually killing sections of their body, and so the body's actually infected, and it's
What are they actually, ice and crocodile?
ice and crocodile.
What is it, what are they?
And then xylazine, the horse tranquilizer.
Okay.
That one causes the lesions too of the skin from IV use. Yeah, and those you can't hit them with Narcan and it won't save them. Those particular.
But you're asking what
And
is.
what are they? That's
So they-
a common name, but what is it?
So xylazine is an animal tranquilizer that's being not only mixed with other substances, but being used on its own. I believe there's been a few confirmed cases in Mendocino County. It sounds like there might be more than I'm aware of. So I have seen patients come into the hospital. We at least in the hospital setting, we only use a drug panel test that is either, from the way that I see it anyway, is a positive or a negative for about 10 different drugs. Xylazine's not on that list, right?
Yeah.
But we had a couple overdoses in this last year where the patients were treated for acute opioid overdose. They responded to the Narcan, right? They came back to, but typically with Narcan, people come back and they're pretty much they're fully awake. These patients slipped back into a pretty sedated state, but they were put on IV Narcan, and that seemed to have some effect. They just had to continually be receiving it. So, and the messaging that I always want to say is that if you think it's an overdose, give them Narcan, because Narcan doesn't have a counter. Like, if I give you Narcan and it doesn't work for the overdose, it can't make you sicker, right? And our Narcan works for opiate overdoses when given time appropriately every time. Like, that's just the function of that chemical, is to it binds to the opioid centers and kicks all of that stuff off. And so everyone should be carrying it. And Narcan works, and if you think it's an overdose, you should probably administer it. There are Narcan trainings available. I am not a very good Narcan trainer. I've never given it myself, so I don't feel qualified. But there are organizations like McCavan and Ukiah and other people that can give you a really good training on how to not only diagnose overdose, but to administer Narcan.
What's happening with right now, and it's also happening with the methamphetamine and the fentanyl and things like that, is that now people are getting chemicals, and there's all these cooks that are coming up. They're popping up all over the place. It reminded me of the meth epidemic, where there was these methamphetamine stills all over the place in the houses, and they're taking up houses. Well, that's happening now with the fentanyl, and there's different strains of fentanyl. There's I think last time I heard there's 12 different kinds of fentanyl, and each one is more intense. So, you got the fentanyl, and then there's the carfentanil, which can be 10 to 100 times more stronger, and then you've got other ones that are stronger than that. So, as these chemists that are backyard chemists are putting the drugs together, it's really hard to say what we're going to end up with. They're apparently getting their supplies from out of the country. A lot of China was sending a lot of stuff in, and so they're getting things from Mexico. And now people are they're in manufacturing mode. And what's happening is just all kinds of really bizarre stuff that we don't even know what's going to come up next time, It's a combination. But anyway, what they're doing right now is everybody's really into these speedballs, which is now they're reproducing methamphetamine bathtub type, like made at home meth mixed with fentanyl. So, IV. So that's the new thing that's happening, so they can be up and down at the same time. Yeah. So I also wanted to let you know that the death rate that I looked up on the current death rate from 2016 to 2021, I've got a current one, was 300% more people were dying from fentanyl overdoses than previously. So it's just getting worse and worse and worse.
we've actually seen a slight downturn.
Are we?
I mean, we're definitely on a spike. I just saw data the other day that suggested that, I'm not saying like we're way down, but it's like this, and then we're actually starting to see a little bit of leveling off in California,
that's good.
which is a great sign. But we're still it's still way up here. It is very scary.
And
Maybe county statistics?
I think California statistics are the one that I saw.
yeah,
so
what
maybe
about
that's the difference.
Methamphetamine County? Weren't you just saying that we were number 2?
Oh, I don't. The statistics for methamphetamine aren't quite tracked the same because it's a lot easier to track overdose deaths than suspected methamphetamine use, I believe. And I don't know. I know from what I see in my work, it seems like actually methamphetamine and alcohol use disorder are way bigger problems in this county than actually opiate use disorder. The problem with opiate use disorder, or people who use opiates, is it's highly more deadly. But that also is a little murky because from my anecdotal experience, the people who tend to be dying from and experiencing overdose more often are people who intended to use methamphetamine and are opiate naive, and so they're not used to using it. They weren't expecting to use it, and so they're not prepared, and they tend to overdose, right? And they're the ones who tend to be the fatal ones. That's just kind of, again, my anecdotal. A lot of people, whether it's true or not, claim that they weren't intending to use opiates. They thought it was cocaine, they thought it was Xanax, they thought it was something else, and they're the ones who are actually experiencing. Not to say that people who use opiates don't accidentally overdose as well, but in the way that I remember it, we're seeing a lot of people not intending to use opiates, and they're the ones that are dying.
The scary part about it is it's so tempting of a drug that even though they overdose, they usually go back for more.
And most fatal overdoses is when they created the program that birthed what I do. Most fatal overdoses occur 48 hours after an intervention of an overdose. So someone overdoses, is brought back to something like Narcan, and then the fatal overdose is the next time they use, because not only the Narcan wears off, and now they have like twice as much on board. So that's why these kind of services are so important, because they can go from an overdose to being in a MAC clinic in less than 48 hours sometimes.
Right, yeah, we have immediate needs same day. We've got a process set up that we can get somebody from the ER and into the program within that same day, within hours. Yeah, for the ones that are high needs.
And we have had luck also. I had a patient come in from an overdose and make it to residential treatment same day last week in Ukiah Valley Hospital. So
Yay.
we're doing some good work with
That's great.
Ukiah Recovery Center as well, who's just, again, opened a bunch of new detox beds. So, yeah.
Any other questions? I just want to thank you, Suzanne, very much for putting this together. I appreciate it. You put a lot of work into this, and I appreciate it. And I don't know what happened to my speakers, but
Oh, it's
yeah.
okay. Thank you guys for the really important work that you do. You're saving lives and getting the information out, so we really appreciate it.
Thank you.
Yeah.